In the United States, there are over 135 million visits to the emergency department every year. Each hospital's ER must be prepared to treat patients of any age, at any time, with issues ranging from a slight fever to a life-threatening injury. On today's show, if you need emergency care, we will tell you what you should expect and where to secure expert quality care quickly. On today's episode of CHS Presents Lifestyles at the Heart of Health. Hello, everyone, and thanks so much for joining us. I'm Jane Hansen. Catholic Health Services offers care at multiple locations throughout Long Island. And joining me now are Dr. John Frankfurt, Chairman of Good Samaritan's Department of Surgery, and Maureen Sheridan, the Director of Trauma Services, also from Good Samaritan. Welcome, and thank you both for being here. I'm kind of startled by the numbers about how many people you treat there, Dr. Frankfurt.
Good Samaritan Hospital is a complex, comprehensive center, and it treats an awful lot of patients because of the population that we serve. We serve a catchment area of over 650,000 in Southwest Suffolk. We see between 85 and 90,000 patients in the emergency room on a yearly basis. And those patients need to be evaluated, treated. Some of them get admitted, some of them get treated and discharged.
That's an amazing number to think about, and to have to deal with all of that. I'm sure that they've got everything from a sore toe to serious traumatic injuries. How do you do all of that?
Well, the emergency room physicians do a fantastic job in sorting out those patients in conjunction with nursing. Those patients that get triaged, those patients that require just minimal care may go to something called fast track, where they're seen, taken care of, and discharged. Those patients with significant problems end up being seen in the main emergency room, and then specialists are called if we feel we need to bring them in order to care for the patients.
But you've got specialists on call all the time?
All the time.
24/7. Now, Maureen, talk to me about what most of the injuries stem from.
Well, I think, if we had looked at this 5 years ago, we would have said motor vehicle crash, but in the last 5 years, what we've seen is falls has far suppressed motor vehicle crashes as the #1 cause of injury in our trauma center.
Falls, though, are we talking about elderly people?
I think the falls are our #1 reason for injury across the ages. And so a lot of the patients that we get are not just elderly, they're young people who fall because of the footwear that they wear, older people that are very vigorous and out cleaning their gutters on ladders, people who go ahead and trip over rugs in their house, things like that.
So really it's about wearing the wrong footwear when they're doing things, or just not being careful, maybe the wrong ladder or something like that?
It can be the wrong footwear, it can be the wrong lighting, it can be just moving from one surface to another surface, it can be any of those things.
Talk to me a little bit, Doctor, about how one becomes designated as a trauma center. You must have to meet certain criteria.
Absolutely. And the whole thrust of this is patient-focused care. We need to be able to deliver critical care services to those patients who need it most in order to save their life. To establish that, we have to have a special team, a team of physicians, which starts with the emergency room physician, and in particular Good Samaritan Hospital Medical Center, we have an in-house trauma surgeon 24/7, 365, meaning that there's always a surgeon available and waiting in the institution should someone be injured. That's complemented by the rest of the members of the team, including nurses, respiratory therapists, anesthesiologists, and operating room personnel. We have 2 operating rooms that are available 24/7 every day of the year, and that means including through the night. All the resources need to be brought to bear. That's only part of it. We need blood bank services 24/7, CAT scan services 24/7. So a specialty trauma center has to have the resources, the capabilities, and the personnel, and this involves hundreds and hundreds of individuals on a daily basis.
Maureen, is there specialties aimed at pediatric trauma too?
Yes, in fact, Good Samaritan Hospital is only one of the very few hospitals in the state that has asked for dual designation, meaning designation as an adult trauma center and as a pediatric trauma center as well. We have a broad group of specialty services that belong to critical care and pediatric emergencies. And so all of this is done as a side to the fact that trauma centers in this country are going ahead and gearing up for children in general.
Can I just make one point
Of
in
course.
addition to that? Good Samaritan Hospital Medical Centers had a pediatric emergency room for more than a decade. We were the only one in Suffolk County to have such a designated pediatric emergency room. And around that, we surrounded it with a pediatric intensive care unit, pediatric emergency room physicians, pediatric surgeons, so a whole cadre of individuals, and finally specialists, cardiologists, GI specialists, etc., to care for those patients. But this is what you need in order to develop care for patients who have significant injuries.
But what's the difference between adults and pediatrics? I mean, obviously the size of the patient makes a huge difference, but I'm assuming that we see different kinds of injuries with them.
Their response to illness is very different too. Children tend to look very good until they look very bad. And so you have to have a very acute, heightened sense of awareness as to what the injury or an illness is and what their normal response would be to go ahead and make sure that, in fact, you treat them properly.
Well, talk to me about fast track, because emergency rooms of old, I can recall being there where you're sitting for hours and hours and hours before you're even seen. And obviously you don't want that to happen to people. So fast track kind of gets rid of that.
Yes, Fast Track takes care of those patients with minor injuries or minor problems that can easily be seen by either a physician or a PA, and they can be triaged and treated very quickly. So if someone comes in with a urinary tract infection or a simple laceration, not necessarily a life-threatening problem that requires deep evaluation.
But it's probably something that happened over a weekend or maybe at night when people get worried, right?
Certainly, and I think that's one of the reasons why you see these urgent care facilities pop up too. They take care of the patients who don't have significant injuries. Fast Track does the similar sort of process, but at the medical center.
But that's good for you to have those urgent care centers, et cetera, because that means people who don't need that heavy-duty trauma can go to them.
True.
Yeah. So when you talk about these patients coming into the hospital, talk to our audience about when you really need to go to the emergency room. What symptoms should you look for when you know time is of the essence?
Well, in the trauma setting, obviously, it's pretty apparent. Someone falls down and someone has significant pain. They're not getting better. It isn't just a bruise. That's a big issue. Motor vehicle accidents are our second biggest one. When someone suffers an injury, they need to go for a proper evaluation. They may have headaches. They may not be seeing clearly. Someone may notice that don't have proper speech. They're not walking. They may have broken arm, or they're bleeding. So a trauma center sees patients based on the need and based on how the patient feels. And if that patient doesn't feel right, they need to go to that center.
And I guess that's the bottom line, right, Maureen? If you don't feel well and something's really bothering you,
Tell somebody.
yeah, tell somebody and get some
Get
help.
some help.
And it must be rewarding, though, to be working in this department because of the immediacy of what you're able to do for people.
Well, you know, for many years you always worked with a younger group who were normally healthy and then suddenly were not healthy. And so to see them return to normal function and be able to go on and live with their life, you know, you can't ask for more than that.
Yeah, same for you, I'm sure, Doctor.
Oh, absolutely. I mean, the whole reason that we got into medicine is to help people. And one of the nice things about medicine, and particularly surgery, which is the reason I became a surgeon, is because I could take care of someone and I could restore them to health. You can't say that about a lot of different areas of the society or disciplines in surgery and medicine.
That's for sure. Thank you both so much. We have to take a quick break, but still to come, an infection that is expected to increase steadily over the next several years, and how important the early critical care in the emergency department is for these patients. That's all when CHS presents Lifestyles at the Heart of Health returns. Welcome back to CHS Presents Lifestyles at the Heart of Health. Sepsis can be deadly. It kills more than 258,000 Americans every year and leaves thousands of survivors with life-changing effects. While there are many deaths, according to the CDC, there are also over 1 million cases every year where early recognition and treatment of sepsis in the emergency department has shown to significantly improve survival rates. Joining me now is Dr. Kurt Dishner, the Assistant Director of Emergency Services at Mercy Medical Center. Welcome. Thanks for being here.
Thanks for having me.
So give us the definition. What is sepsis?
Okay, great question. So people hear this term a lot, and sepsis is a body's systemic response to an infection. So what happens when there is an infection in the body releases these chemicals for the treatment of the infection. What happens is these chemicals cause an inflammatory response in the body. And this can be manifested such as an elevated heart rate, elevated respiratory rate, potentially a fever, or an elevated white count. And the problem with sepsis is that it can progress. It can progress to something called severe sepsis. Severe sepsis is when sepsis gets to the point where it starts to adversely affect the patient's organ systems, such as possibly the brain, the kidney, the lungs. And from there, it can potentially lead to something called septic shock. Septic shock is when you have septic patients who, despite intravenous fluids, aren't able to maintain a normal blood pressure. And it's at this point where the patient can really start to go downhill. The patient can then start having organ failure and possibly death.
And this can happen. I mean, the big deal about sepsis is this can happen very quickly.
It can. And it really kind of depends on the patient, especially in the very young or the very old, or patients who have been, immunocompromised. Maybe they're on chemotherapy for cancer or something like that. So when they don't have an immune system that's not up to, a normal immune system, they're more prone to going downhill quickly and more prone to infection.
And isn't it also true that it can kind of be the symptoms of so many other things?
Yeah, it can be. So really, sepsis is, again, you could start with a simple urinary tract infection, possible pneumonia that's localized, but then what happens is it starts to spread and you get this inflammatory response and you start getting these additional symptoms.
It's really scary to think about. So how do you, when somebody comes into the emergency room, are there methods in place right now where you immediately screen for that no matter what?
There are. Mm-hmm. So when every single patient that comes to our emergency room is screened for sepsis. And this is done initially when they first hit the door and done in triage. So what we do is our triage nurses will screen for sepsis by asking certain questions. Are you having fever, chills? Are you possibly immunocompromised? Maybe the patient, like I said, has cancer and they're receiving chemotherapy. And then they screen the patient by looking at their vital signs. Do they have an elevated heart rate, an elevated respiratory rate? Are they having fever? And if the patient has enough abnormal signs or symptoms, we have something called the BPA that fires in our EMR, which is our electronic medical record. And this alerts the nurse that this patient may be having sepsis and that they need to notify a physician of a possible sepsis case.
And then what happens?
Great question. So at that point, the triage nurse will notify the doctor in the emergency room. The doctor comes to bedside to do a rapid assessment of the patient to determine if they may or may not have sepsis. The doctor feels like there's a possibility of this patient having sepsis. We initiate our sepsis protocol. That involves giving the patient intravenous fluids, giving them broad-spectrum antibiotics, and then trying to determine what the source of the infection is. And we screen, look for the blood through blood cultures, look at the urine through like a urinalysis, and at the lungs, maybe a chest X-ray to look for pneumonia. At that point, then, we'd also then want to give supportive care to the patient's respiratory and circulatory system as needed.
Mm-hmm. So can any infection turn into sepsis? It can?
It can. Mm-hmm. I mentioned a urinary tract infection, pneumonia, even a simple strep throat could potentially progress to something like that. Meningitis, there's any sort of infection can spread to become sepsis or
that is
severe
just
sepsis.
Frightening. So you start these antibiotics, or you start this treatment medication, but it's kind of a big picture first, and then you narrow it down as time goes on.
Exactly right. So that's kind of how the point of it. It's sepsis treatment or severe sepsis treatment. It's about early recognition and early treatment. And in the very beginning, we don't know exactly what the source may be. So we use something called broad spectrum antibiotics, which when we give it, we know it's going to cover most possible infections. And then when we determine exactly what the infectious source may be, we can then narrow the antibiotics down to just make sure we're covering that organism.
So for people that are watching this at this moment, I'm just wondering, how do they know when something is severe enough that they should go to the emergency room?
So, it's another great question. So, if a patient is, having, fevers or chills, they're not feeling well, they're feeling maybe impending doom, they're feeling like they could potentially die, that's not something you want to sit on. You want to either be calling your primary doctor or coming right to the emergency room to be evaluated.
So how many cases of this do you see a year? Do you see a lot of it, or is it just the screening process quickly eliminates it? So
we do see a lot, quite common. We at Mercy see a good number of nursing home patients, and nursing home patients do have, more prone, they have elderly patients. So as a result, they're more prone to having, infections and severe sepsis. So these patients we see a lot of, and as a result, we see more sepsis patients.
Right, but anybody can have sepsis. I mean, you could be a little baby,
Anyone
and
can.
you can be
An adult, me, you, anyone.
Right.
But just at the advances of age, very young, very old, are more prone to it.
Okay, but I mean, if anyone can have it, is there anybody that's more prone to it other than, the elderly and the young? I mean, like a normal human being that's maybe in their 30s or 40s. Is there something that's more prone to it or not?
Can they get one?
Yeah,
Yes.
I mean, are some people more prone to it?
If their immune system is compromised, again, say they have, they're on medication for, say, cancer, they're getting chemotherapy.
Okay.
Maybe they're receiving something for, say, methotrexate for rheumatoid arthritis. Anything that adversely affects the immune system can make them a higher risk for having it.
But the great statistic in what I just read is that there are over 1 million cases, the CDC says, in the U.S. that are actually caught early enough, and that's the important part. Time is of the essence.
It is. So as you mentioned, there is a lot of cases. There's over 1 million cases each year of sepsis, and of that, over 250,000 of these patients will actually die from that. And that's actually more deaths than breast cancer, prostate cancer, and AIDS combined. And this is a result that severe sepsis has a high mortality rate. 20 to 50% of these patients will die if they progress to severe sepsis. And as you mentioned, early treatment and recognition is key. When we are able to recognize these patients early and initiate therapy, we can actually reduce mortality rates significantly. There's some studies out there that show that we can reduce mortality rate by 22% and also result in a decreased length of stay, so how many days we have to keep these patients in the hospital.
So that's why it's important to make sure you get to the emergency room early, and that you guys do all of this work up front to determine who's got it and who doesn't, and how to treat them appropriately quickly.
Exactly.
All right. So thank you so much for being with us today.
Thanks for having me.
We really appreciate it.
Great.
We're going to take another break, but we'll be back right after this. Welcome back to CHS Presents Lifestyles at the Heart of Health. Joining us now to continue our discussion about emergency room services is Dr. John Matthew, Director of Emergency Medicine at St. Joseph Hospital. Welcome. Good to have you here. Once again, you serve an awful lot of people. You're a community hospital, but how many people come through the emergency room?
So at St. Joseph Hospital, which is one of the Catholic Health Service hospitals, we see about 34,000, a little over 34,000 patients a year. The hospital itself serves probably over 56,000 patients a year.
And once again, you've got to be prepared for just about anything to come through those
Anything
doors.
and everything. I mean, I think all emergency departments nationwide, we're ready and set for anything that walks in the door, whether it be from trauma services, whether it be from mental health services. There's everything that can walk through the door, and we have to be prepared for it.
You guys have some specialties in like spines and orthopedics and
Correct.
that wound care, that sort of thing.
Yeah, so we specialize in certain things at the hospital. We see everything, but we do have a great orthopedic and spine care center there. We take care of patients. We do perform surgeries for these patients here. We have MRI 24 hours a day available. We have CAT scan 24 hours a day available. We do have hyperbarics for wound care, which we do very well at St. Joseph Hospital. We even have a cardiac CT program that we're looking at, It's sometimes very difficult, a community hospital to really take care of certain patients, right? Somebody comes in, walks in with a heart attack to your hospital. What are you going to do for that patient? So that's why it's important that we have a good team, a Catholic Health Service team that we can take care of these patients very well. We have established connections with St. Francis Hospital, with Good Samaritan Hospital, with Mercy Medical Center. So we take care of these patients as well as possible and get them to the right place when they need to be.
Which means that you can actually transfer patients within the system, providing once they're stable, I'm assuming.
So again, we want to take care of our patients at our hospital, but we understand where our shortcomings are and what we can take care of and what needs that higher level of care. When we have a trauma patient like Dr. Frankfurt and Maureen were talking about earlier, if it needs that higher level of care, Good Sam is one of those centers that have that level of care that can take care of our patient. When we're talking about heart health, St. Francis is our heart center for Catholic Health Services, and we can make that quick phone call and get that patient taken care of very quickly once we stabilize that patient and treat that patient.
So people can be assured that they're going to have whatever if they've got a
Correct.
need for really specialized
Correct.
care.
And we don't want people to be afraid to come into a community hospital. You need to be taken care of. If this happens right across the street, come to the hospital, we'll stabilize you, we'll take care of you. A lot of the times it's something we can take care of here, but they need to be reassured that we can take care of them within the health system.
And when we use the word emergency, usually we mean that time is of the essence.
Correct. There's so many things. Even earlier you were talking about sepsis, stroke, trauma. It's all time is of the essence to take care of these patients.
So what is it? You offer this, one of your unique services called Arctic Sun Temperature Management System. What is that?
Well, that's actually just the name of the system, but what it entails is actually therapeutic hypothermia, or actually temperature treatment for patients that come in cardiac arrest. We're looking, and the studies have been out there, looking at outcomes of these patients that come in. Yes, we've resuscitated them, we've brought them back, but how do they do 6 months, 1 year later on? And what we've really been able to prove is that patients that we can cool, and it seems counterintuitive, we're bringing these patients' temperatures down, but it actually preserves brain activity, and actually these patients do a lot better. So we have protocols set up. If we can get these patients and we resuscitate them within a certain amount of time, we can cool them to the appropriate temperature, and they do a lot better.
How much do you cool them off?
Well, they can come down to, and I'm going to say in Celsius, it's between 32 and 34 degrees, but if you turn that over to Fahrenheit, it's around 90 to 92 degrees Fahrenheit that we're cooling them down to. You don't want to go too low, you don't want to go too high. You had to get them into that right temperature, and that's why that system works very well. It does instantaneous, and it watches every second, every minute what the patient's temperature, core temperature is.
That's amazing.
Yeah.
I just, wow, it's a pretty major system. So in general, when we're talking to our audience here, well, I guess the thing I'd like them to be assured about and to understand when they come to St. Joseph, what should they be looking for before they walk in your door?
Well, we don't want them to look for anything. If they're seeking care, they can walk in and they can seek care. We'll take care of any issue that happens, anything that is bothering them. We can take care of and we can assess. A lot of the times you may not know. You think that it's something that's just a cough or a cold or congestion, and there's something that's there. And so we don't want to let them know that, oh, you need to have this and this and this to come to our emergency department. If there's a concern, we're here for you and we can take care of you.
So what is it about emergency care that attracted you to it? I mean, what does it bring to you?
So for me, it was always being on my feet and being ready to face the next challenge. You don't know what's going to walk in those doors. We never close the doors to the emergency departments, and the ambulances never stop coming. So you have to be on your toes 24 hours, 7 days a week, 365 days a year.
And so do all of your colleagues. I mean, how
Correct.
many people? You've got everybody there.
Correct. We have. I mean, we'll have all our consultants. We'll have all our nursing. We'll have all our techs, and it's a whole team that really takes precedence here. It's really not just the emergency physician. We have physician assistants. We have nurse practitioners. We have nurses. We have techs. Everybody is needed for the care of that patient.
And we've talked earlier about the size of the communities. We talked about that at Good Sam. So how many people do you actually serve? It's
When
pretty
you say
large.
serve, you're talking about just in our catchment population?
Yeah.
It's hard to say. I mean, if I just took a look at that area, just in Nassau County, between Good Sam, between Mercy Medical Center, there's got to be at least 500,000 patients in that area.
Right.
Now, in our catchment area, there's probably at least 200,000 patients.
How has emergency room care changed over the past few years? Because I know you've been at other hospitals. Do you see more of certain kinds of things now than you used to and less of others?
Well, at times, it really depends. Now, with healthcare changing the way it is, we're always that center that somebody can come to and seek care. So that hasn't changed. There's certain things that have changed with the emergence of, doctors' offices being open a little later, urgent care, that some of these minor things can go there. But whenever anyone needs something, they're always going to come to the emergency department. So we're always there. Now, the things that have been changing is always you want to look at better outcomes for our patients and to be prepared for things. Just as Dr. Dishner was talking about sepsis. early recognition, try to treat those patients as soon as possible to take down those numbers. We've been treating sepsis for years and years and years, but as we learn more about sepsis, as we learn our protocols can be better to treat these patients, we're going to continue that. And that happens with anything, whether it be cardiac care, whether it be stroke care, whether it be sepsis care. We're learning as we go, and we're going to continue to make leaps and bounds forward with our treatment of these illnesses.
Well, we like that a lot.
Yeah.
I'm going to invite everybody to come back in and join us as we just have a few final words here. I guess my thought is, how has technology changed things in the emergency room? Has it really helped? Perhaps Dr. Frankfurt?
Absolutely. The things that we can do now include immediate resuscitation of patients, rapid transfusion of patients with warm blood products, placement of chest tubes in airways, difficult airways that we may not have been able to do before. So by having the appropriate team in the appropriate location, whether it happens to be a pediatric patient, a pregnant patient, an adult, or a geriatric patient, those extra resources really make the difference in the outcomes.
And I'm assuming that that's going to get even better as time goes on. The technology and that sort of thing.
Oh, 100%. I mean, things are changing every single day. There's new innovations. I mean, just being able to access patients' medical records, see what tests they've had, not having to repeat tests, being able to see previous consultations and information is just so valuable.
And Maureen, last words from you. Talk to me about what it means to you when a patient comes in and you're able to get them out the door a few days later healthy and happy.
Oh, I think there can't be enough said for bringing back patient to their original functioning condition. We spend a huge amount of money on health care, and as we spend this money, you want it to be well spent. And I think bringing patients back so that, in fact, they can have good, productive lives, you can't do any better than that.
Well, thank you all for the great work that you do. It was a pleasure to have you with me today.
Thank you.
Thank you.
Thank you.
And as always, for more information or to schedule an appointment at one of Catholic Health Service's 6 outstanding hospitals, you can call 1-855-CHS-4500 or visit chsli.org. Thanks so much for joining us today. I'm Jane Hansen, wishing you goodbye and good health.